So the next session will be on CA larynx and hypopharynx. And I'll request Dr. Colonel Gunjan Dwivedi ma'am and Dr. Colonel Sunil Goyal sir to start the proceeding. Hello.
Am I audible?
So we'll be starting with the CA larynx and Dr. Colonel Sunil Goyal sir will be taking up.
First of all the best for your exams. So we'll briefly take you through some of the common questions which may be asked during the exams. So I'll be covering the topic under these heads. So if we talk about the disease burden, you want it to be an interactive session or a monologue? Practical aspects. Practical aspects. Yes, sure. So it comprises 2% of all cancers and is the second most head and neck cancer. If we talk about the gender, it is more common in males, age, middle age and elderly. And as we are all aware, the common risk factor, if somebody asks you, it is the smoking and alcohol, and they both have a synergistic effects. So can anyone tell me what are the various carcinomas which we can encounter, or which are the various malignancy which can be seen in larynx? Squamous cell carcinoma. Anything else? So you should be aware about there are WHO classification, and there are various other types of carcinoma which are also can present in larynx. So it is not all cancers of the larynx are squamous cell carcinoma. So there can be neuroendocrine tumors, salivary carcinomas, or one of the others which we were mentioning. If we talk about pathophysiology, so it takes several years before the carcinoma presents to us. So if you are asked, then you should be able to tell that the disease progresses through hyperplasia, then dysplasia. Of course, you should know the pathophysiology, how the inciting agent leads to all this thing, and the genetic factors. If you are doing well, then they may ask you what are the other genetic factors and markers which are important in the transmission and formation of the carcinoma. So it goes through hyperplasia, dysplasia, carcinoma in situ, and finally the invasive carcinoma. Next commonly thing asked in a viva would be what are the subsites of larynx. So can someone tell me what are the sites and subsites? Anyone? So the sites are supraglottis, glottis and subglottis. And if we talk about what are the subsites of supraglottis, it is the suprahyoid and the infrahyoid epiglottis, airy epiglottic folds, ventricular bands and laryngeal ventricle. And for the glottis, it is the true vocal cords and the anterior and posterior commissure. There are no subsites in subglottis. Okay. Another thing which the examiners are fond of asking is what is the oncological definition of glottis? Anyone? Oncological definition of glottis. Anyone? Yes. So if you can read, sorry. As per AGC, it extends from the apex of the laryngeal ventricle to 1 centimeter below the superior surface of the vocal cord. So that is the extent of glottis, and subglottis will be from the lower border of the glottis till the lower border of the cricoid cartilage. And what are the common presentations of a supraglottic cancer?
Foreign body sensation,
Okay.
throat and globus.
Foreign body sensation,
Dysphagia.
dysphagia,
Lymph node presentation. Neck node.
yes. So we should remember supraglottis can also present as neck nodes. So common presentation would be a dysphagia or a neck node, and while in a glottis it would be hoarseness, and in a subglottis it would be more commonly it would be stridor. So they present late. So since glottis carcinoma presents with hoarseness, they present early and we are able to usually detect them early, and so they have a better outcome, and moreover they don't have any lymphatic metastasis are uncommon in glottic cancer. Other thing, the patient may come to you with a already a patient may have undergone a tracheostomy for either a biopsy or stridor. What is the performance status? Anybody? Yes, can you name some scales? ECOG full form? Anybody? Eastern Cooperative Oncological Group. This is very important in decision making. Performance status 0 and 1 are good patient who can tolerate the surgeries. Any performance more than that is considered not good situation. So this is a table comparing both the Kornofsky and the ECOG status. And how do we determine what performance status the patient is in? So what question should we be asking the patient? So, okay. So the first question, as you correctly mentioned, is the patient able to carry out his or her normal activities? If the patient is able to carry out, the patient would be performance status 0 or 1. If you go, so the next question would be, does the patient have any symptoms? That will determine whether what ECOG it comes under, 0 or 1. If the patient is not able to carry out daily activities, it would be performance status more than 1. So next we would be evaluating the patient. So what is the common modality which you use in your hospital? You all do ideal or you do Hopkins? Pardon? Fiber optic. So apart from doing fiber optic laryngoscopy, anything else you should be examining at the same sitting? Oral cavity. So we have to examine complete head and neck examination. We should look at all mucosal. We should look at all mucosal sites because one can have a synchronous primary also. So do not jump into that the patient is presented with hoarseness and I will just do a laryngoscopy, and same thing should be mentioned in the exam that I will also do a nasal endoscopy and rest of the examination. So there are so common examinations are this, and various findings which we can get is maybe a leukoplakia, leukoerythroplakia, ulcerative lesion or a exophytic lesion. Or it may just look something like a granulation, irregular granulations. So don't miss out on this thing, and this things, all this patient needs to be undertaken for a biopsy. So once we examine the patient, we should try to remember all these things has to be assessed, which is the primary site, the nature of the growth, because a leukoplakia may have a hidden malignancy along with it, so they need to be taken for biopsy. Extension to adjacent site, that will help in staging, as we will be discussing later. The mobility of the cords, neck node status, and say suppose the lesion is extending superiorly towards the oropharynx. So this patient may be unresectable for surgery. So most of this thing can be examined in the OPD, and to confirm this thing we have to take the patient for. So the aim of DL-scopic biopsy is the most important function is aspiration. Patient may have microaspiration if that is not leading to any symptoms or any clinical findings, that can still be considered under functional larynx. But if the patient develops pneumonia or requires hospitalization, other features are, if the patient requires a tracheostomy, then you should determine whether the tracheostomy was done just to take a biopsy, say that it was a glottic, and for a biopsy tracheostomy was done, or was the tracheostomy done for it being presenting with a stridor. Other aspect could be hoarseness and dysphagia. So what investigation will you ask for? Okay. So basic investigation. Apart from that, we need a biopsy and CT scan. Where in doubt, in certain scenarios, MRI can be asked for, especially at times for differentiating between a T4A disease and T4B disease also, whether the prevertebral space is involved or not. So, MRI may be useful in those scenarios. So, we need a contrast enhanced CT, it should be high resolution, and at laryngeal level we may even ask for 1 millimeter sections, so that we can know exactly how the disease has extended. Neck and chest CT should be combined, because it also helps in determining the metastatic status, and in case the disease is extending towards the PFS, say the disease is arising from the area epiglottic fold and extending towards the pyriform sinus, then the radiologist may be asked to do the CT scan with a Valsalva maneuver. That will open up the PFS spaces and we can visualize the extent of the disease better. So, as we discussed, so we have to know the extent of the disease, the primary site, the extent, and to stage the disease we have to know whether the pre-epiglottic space, paraglottic space, inner pericardium is breached, whether the cartilage is breached, or it is extending extralaryngeal through the membranes. So, any of this will help us in determining the stage of the disease. Along with that, the nodal stage and condition of the chest if there is any suspected foci. So, briefly we will talk about T staging. Anybody? Supraglottic carcinoma T1? So, simply the vocal cord should be mobile and it should be one subside. If the larynx is not fixed, one or more subside, it is T2. T3, T4 I will be talking together. Similarly, in glottis, T1 is, it is limited to the vocal cord with mobile cords, and T2 is with impaired cord mobility, and it may extend to the supraglottis or the subglottis. Similarly, for subglottis, if it is limited to the subglottis, it is 1, and if it extends beyond the subglottis, it is T2. And for advanced T staging, if the vocal cord is fixed or the pre-epiglottic space, paraglottic space, or the inner pericardium is involved, so that would be T3. T4 would be anything outside the larynx is T4, and if the disease extends to the prevertebral space, carotid space, or the midrectal structures, it is T4B. Any other structure, it is T4A. Nodal staging, I think, has already been discussed in the previous lecture, so I won't be going into it. So, distant meds, of course, we would be evaluating the patient. So, how do you stage the disease? All are aware about the staging? So, this is a chart, schematic chart, which I keep in my mind whenever I think how to stage the disease. So, anything N0 and T1 would be stage 1, T2 and N0 would be stage 2. So, keep note of only the highest nodal stage and the T stage. If the disease has N1, it is minimum stage 3, or if it is T3, it is minimum stage 3. Similarly, if it is T4 minimum or N2, then it does not matter, it is N2A, B or C, it is stage 4A. Similarly, T4B or N3 is stage 4B, and any M1 is stage 4C. Treatment part I think we will be covering later on, ma'am, we will combine with that. So, the next part of this presentation is hypopharynx, so we can cover the treatment part along with that. So, goals and all, everything would be usi mein kar denge, ma'am. So, the main goals of the treatment are to maximize the cure in larynx, preserve the function of larynx, we are moving more towards preservation of larynx, preserve the quality of voice. Even if you are doing a laryngectomy, we should try to put a TEP to, or some other form of voice rehabilitation, and try to give patient the best quality of life possible, and palliative treatment if the disease is incurable or undesectable. So, this we have already discussed. So broadly speaking, stage 1, stage 2 disease is a single modulated treatment which may be surgery or radiotherapy, and advanced stage disease would be a dual modulated treatment, and unresectable disease or a metastatic disease would be a palliative treatment. Tracheostomy, how would you prefer to do a tracheostomy, low or a high tracheostomy? High. Why? Stomal recurrence. So we have to think about stomal recurrence. So I am skipping the treatment part. What are the indications for adjuvant radiotherapy? Okay, and chemotherapy? Right. So this we should remember. And other scenarios, as I think ma'am would be mentioning later, if it is a large volume disease or it is a high grade tumor, also sometimes radiotherapy can be considered. Follow protocol for the first 2 years is every 3 months, up to 5 years it is every 6 months, and even after 5 years there is no recurrence, we have to keep the patient under follow up, preferably every 1 year. Aim is to detect early recurrence, the morbidity of the treatment, and any second primary. And what all should we look for in a follow up? If we know the aim, it is very easy to understand. So we have to look for local regional control, any second primary, and late sequelae of treatment. Say the patient has been given radiotherapy, so the sequelae of radiotherapy would also be there. Maybe a chondronecrosis has happened later on. So we have to consider all those things. Baseline imaging should be done. PET scan should be done ideally after 12 weeks of the completion of treatment. And if the patient has undergone any irradiation to the neck, then thyroid function test also needs to be checked every 6 to 12 months. And post radiotherapy, we also have to think about xerostomia and osteoradionecrosis. So patients should also be asked to undergo dental evaluation regularly.
Hey, good morning everyone. So I'll be talking about carcinoma hypopharynx. Larynx and hypopharynx are generally covered together because the treatment modalities are similar in both the cases. However, we have to understand that the two are very different diseases, and carcinoma larynx is not that bad as is carcinoma hypopharynx. Carcinoma hypopharynx is a very, very bad disease with very poor outcomes. Okay, simple things. Starts from hyoid, finishes at cricoid, 3 subsites, all of you know, and it is continuous with the esophagus. Questions on epidemiology can be asked, like what percentage? They are not very common. 5 to 10% of UADT cancers are carcinoma hypopharynx. Very poor outcomes across all stages, that is stage 1 to stage 4, the 5-year survival rates are just about 30%. In patient characteristics, most of the cancers, elderly patients. It is more common in males. Reason, again, because of the habits, that is tobacco chewing and smoking. And they generally present very late because the symptoms are of food sticking in the throat, which people keep on ignoring for a long time. It is not like larynx, where little change in voice, hoarseness, and it is a very prominent symptom. But in hypopharynx, it is just about some food sticking somewhere. People keep on ignoring it. And once the dysphagia becomes really gross, then people present. And that is the reason for the late presentation. So most of these cases present to us when they are stage 3 and 4. And the other reason is, one is ignoring symptom. And the second reason for presentation late is development of neck nodes. Hypopharynx has got a lot of lymphatic supply, and it can immediately go to the local lymph nodes through the lymphatic channels. So even if one node is metastatic, it is straight away stage 3. Single node positive in head and neck is stage 3, so advanced stage. And of course, they are cachectic when they present because of the poor nutritional status. They are unable to eat, swallowing is difficult, dysphagia is there, and so the nutritional status is poor, and that has impact on the management because performance status will go down. Okay, as per some data, 83% of these tumors arise in the piriform fossa. 9% in posterior pharyngeal wall, and 4% in post-cricoid. So least common is the post-cricoid area. And these cancers are more prone for submucosal spread. So when you do a scopy, you will see an ulcerative or proliferative growth, but please do not think that it is confined to that area only. There is a lot of submucosal growth. 1 centimeter superiorly and 2 centimeter inferiorly is the margin that we need when we are resecting these tumors. Okay, characters, the histology, 95% are squamous cell cancers. Others can be salivary gland cancers, sarcomas, lymphomas. So biopsy is important before you start doing any treatment. Field cancerization, as is common in UADT, here also, and in hypopharynx, you have to look at esophagus, you have to look at lungs for a second primary. High nodal burden, as I have already explained, levels 3, 4, level 6, and also level 2. This is the order in which they go to. Level 3, 4, 6, and 2. And about 65 to 80% patients, when they present, they will have a lymph node positive. Distant metastatic spread. Again, why? Because they present late and they have a lot of lymphatic drainage. So in most of these cases, carcinoma hypopharynx, we will require to do PET. The indications for PET, this is a common question that is asked. What are the indications of PET scan in head and neck cancers? Very simple. Anybody can answer? Shambhavi? Stand, stand. Loud, loud.
Look for primary nodes, distant mets, to look for
Primary nodes.
primary disease, nose, and if there is unknown primary or a primary disease, distant metastasis, nodal status, to look for recurrence, follow-up.
When do we want to do a PET
Ma'am, in
scan?
advanced disease, we'll prefer for PET.
Okay. So, advanced disease, anybody can ask for PET, but more than that, you have to do a PET scan when you are having multiple nodes
Multiple
positive.
nodes.
If there are multiple nodes positive, that means if it has gone to multiple nodes, there is a chance it can go to anywhere else in the body too. One. Second, lower nodes. Hypopharynx does go to lower nodes, 3, 4, level 6. Lower nodes means supraclavicular disease as well as infraclavicular disease is possible. So in these cases also you need to do PET. Third, of course, if there is a second primary, you have a suspicion of second primary, then you have to do. Bulky node, N3 disease. If there is an N3 disease, please do a PET scan. So these are indications for PET scan in per primum setting, and indications for PET scan we also have in post-therapy setting when we are looking for recurrent or residual disease. So please know the indications for PET scan in head and neck cancers. So most common is lungs, where it goes to, then liver, mediastinal nodes, bones. These are the sites where it metastasizes. Okay, so these are the various differences between carcinoma hypopharynx and larynx. We can start with symptoms. Larynx presents early because of the hoarseness, hypopharynx late because dysphagia is ignored. Nutritional status in laryngeal carcinoma cases is good, hypopharynx it's poor. Laryngeal preservation, generally good in laryngeal cancer cases, because if it's a small disease which has presented early, we can do with a small surgery or we can do with a radiotherapy organ preservation protocol. However, in hypopharynx, they generally present late and they would have destroyed the cartilage, or there will be a dysfunctional larynx when both the cords are not functioning because of involvement of the post-cricoid area. So dysfunctional larynx is more common with hypopharynx, and therefore the laryngeal preservation is poor. Then systemic disease, it is more common of course in hypopharynx, less common in larynx. So I hope you understand systemic disease. It means distant metastasis. And relapses, again, more common in hypopharynx, less common in larynx. So go hypopharynx, very bad disease. Clinical presentation, we have already discussed. Main presentation is dysphagia. There can be odynophagia. And of course, hoarseness, stridor, all these things can also be there because of involvement of the larynx. Neck mass is another presentation. Patient may just present with a neck mass. Another presentation, otalgia. Please give it importance. There may be a small primary lurking somewhere in the hypopharynx and referred otalgia, which will lead to referred otalgia. Anybody can tell the nerve? Which branch? Arnold's nerve. Arnold's nerve. Okay, evaluation as Sunil has already covered. In all these cases, history, you all know how to take onset, duration, progression for any symptom. When did it start? How did it progress? And what is the duration? Habits and performance score, as has already been told, very, very important. If the performance score is not good, we cannot do definitive treatment. Definitive treatment means curative treatment, which may be a surgery or chemoradiotherapy. Both may not be possible. Okay, full head and neck evaluation, as in all head and neck cancer cases. You cannot leave any site because of the field cancerization theory. All the sites have to be evaluated. Oral cavity, oropharynx, nasopharynx, hypopharynx, larynx, neck, everything has to be evaluated. And that you can do with the help of, in the office with a fiber optic scope. And when we need to map the disease properly and take a biopsy, then DL-scope is required. Same time, please look for any dental caries, because later we may be planning to give radiotherapy, and if dental caries are there, they have to be taken care of in the first go. If you are suspecting cancer, please side by side start treatment for dental caries. Laryngeal crepitus, of course. It may be lost if there is disease in the post-cricoid area or posterior pharyngeal wall. Neck nodes have to be evaluated. So how do we go about evaluating these diseases? Any head and neck cancer, you first need to do, what you first need to do is imaging and mapping of the disease and biopsy. So for imaging is required because clinically we can only see 2 dimensions. Surface we can see. The third dimension, that is the depth, we cannot see, and for that we need the imaging. The workhorse in head and neck is contrast enhanced CT scan of the neck, and in advanced stages, stage 3 and 4, we include the thorax also. In the same go, we advise CECT neck and thorax. In early cases, you may just do X-ray chest, but stage 3 and 4, we prefer to do CT chest. As I have already explained, PET scan and even CT chest is a metastatic workup, and when it has to be done, when there is large disease burden, there is increased number of nodes, bulky nodes, please do a distant metastatic workup with a CT chest or a PET scan. General health of the patient definitely has to be evaluated. What to look for in, this is one of the questions very favorite of examiners. What do we want to look for in CT scan? So CT scan, first of all, we of course want to know the extent of the disease, where all the disease is present. Second thing, we want to, if there is just, suppose cord is not fully fixed, it is partially mobile. Then what you need to know is whether the paraglottic space is involved or not. Because sometimes, just because of the bulk of the disease, which may be superficial, the cord may be, its mobility may be limited. So, to upstage the disease, the paraglottic space has to be evaluated. If the paraglottic space is involved, then it becomes T3. But if it is not, then it is still T2. So, paraglottic space, which is a third dimension. Cartilage involvement. It will immediately change your stage and as well as the line of management. When the cartilage is involved, then we cannot go for organ preservation protocol, that is CCRT, because the cartilage doesn't respond well to radiotherapy because of poor blood supply in the cartilage. For radiotherapy to act, we need oxygen, and that oxygen is brought by blood. So cartilage involvement, we prefer to do surgery. Exolaryngeal spread, of course. Extension to oropharynx and esophagus. That also can be seen through CT as well as scopies, endoscopies also. Because if it is going up to oropharynx, again we cannot do surgery, patient will go for CCRT. Esophagus, plus minus. You may do surgery, you may do CCRT, depending on the extent of the lesion. Prevertebral fascia involvement, carotid involvement, they have to be commented upon in CT scan because again, these are pointers for non-surgical management. Neck nodes, definitely we have to see. They are on palpation and ultrasound, the number of nodes that we see is less than what we can see on CT scan. And as sir has already told in his previous lecture, what all to see in the node on CT scan, you all have already gathered that knowledge. So CT is the workhorse, but in some situations we may want MRI. What are those situations where you will ask for MRI? When we are unsure of the involvement of prevertebral fascia. So MRI can give us more information whether the prevertebral fascia is involved or not. And second, cartilage involvement. Now cartilage, whether cartilage has got two lamina, inner lamina, outer lamina, and central part which in clinical terms we call marrow, though there is no marrow there. So even if the marrow is involved, it becomes stage 4. So the MRI will differentiate whether inner lamina of the cartilage is involved only or even the marrow is involved. If the marrow is involved, the treatment changes, so you have to call it stage 4. So this is another situation where MRI is required. And of course, in CKD patients where you cannot administer contrast, there MRI will be preferred. So role of DL scopy. Now we have done FOL and we have got a FNAC proven disease, FNAC from the node, which says it is positive. Do we still need to do DL scopy if we are planning a CCRT? We need a diagnosis from the primary. Always it is preferred to get the diagnosis from the primary. You may be surprised what it turns out to be. Because though 95% of cases are squamous cancer, it may be something else. So you must try and prove from the primary site. DL scopy, how is it advantageous over FOL? FOL is also laryngoscopy, DL scopy is also laryngoscopy. What advantage do you have? Yes? Biopsy can be done with FOL also. You can have a forceps and you can do a biopsy. You can get a bigger biopsy, yes, one. Second, you can lift the larynx up with your scope, take it away from the posterior pharyngeal wall and evaluate the hypopharynx properly. You can see how far down the disease is going because the post-cricoid area and the apex of pyriform cannot be seen on FOL. And even the posterior pharyngeal wall, which is abutting the post-cricoid, cannot be evaluated. So for full evaluation of hypopharynx, you definitely need to do a direct laryngoscopy. Please remember this. Okay, so the checklist before planning treatment, I'll just give you a few tips. I will not go in detail about how we start managing these diseases. Few tips. Very small disease in larynx or hypopharynx, very small disease. You can do transoral laser surgery. You can even use cold steel. If you have robotics, you can use robotics. Very small disease that can be excised with margins that surgery is possible. In stage 3 diseases, T3 up to T3 and a functional larynx. Functional means only two symptoms which we are considering in functionality of larynx here is, one is stridor and second is aspiration. If the larynx is competent enough and there is no aspiration happening or microaspiration is happening even then, and if there is no stridor, then in that case we consider the larynx to be functional. And in functional larynx, we will like to preserve the larynx. So for laryngeal preservation, what is the option we have? CCRT, chemoradiotherapy. So up to stage 3, we can do chemoradiotherapy in T3 diseases. In T4, as I have already explained, cartilage involvement and dysfunctional larynx, we will like to remove the larynx as well as the disease in the hypopharynx. Reason is what? Suppose it is a stage 2 disease only, I mean T2 disease only. But still we want to remove the larynx. Reason is that, what is it? Anybody can tell? Anatomical preservation of larynx may not translate to functional preservation of larynx. And when there is no functional preservation of larynx, then the patient will not be decannulated with his tracheostomy and will continue to have a Ryle's tube for feeding. So the morbidity with that will be much more than post-laryngectomy, where the patient only has a stoma to manage and can be rehabilitated for his voice with a TEP or an electrolarynx or esophageal speech. These are the three ways we manage this. So please understand why functional larynx should be preserved, and dysfunctional larynx, even if cartilage is not involved, why it has to be removed. Okay? Prevertebral fascia involvement and carotid involvement, definitely we don't operate, because we will not be able to remove from carotid. We will give the patient paralysis if we cut the carotid. And if prevertebral fascia is involved, you will not be able to get margins. And if you don't get margins, then you leave behind disease, and ultimately you will have to give CCRT to the patient, which you could have already given. So this I have already discussed. Okay, stage 4C, that is distant metastasis. Patient has to be given palliative treatment. Now palliative treatment, palliative treatment also is two types. You can have palliative chemotherapy and just best supportive care. So for patient to get palliative treatment with chemotherapy, the performance status of the patient has to be evaluated. The performance status has to be good. Only then the patient will be able to tolerate chemotherapy, because chemotherapy has got a lot of side effects. So please understand, palliative treatment doesn't always mean chemotherapy. It means it may be chemotherapy, and it also may be best supportive care. Best supportive care is improve his nutrition. If there is pain, you take care of the pain. If there is some problem with bleeding, you give hemostatic RT or Tranexa or whatever. I mean, whatever is there, you have to give symptomatic treatment to the patient. Follow-up protocol already explained by Sunil. I hope all of you know this. This is one of the exam questions asked. And in follow-up, why it is required, you need to know whether there is any residual disease, any recurrent disease. Recurrence can be at the primary site, it can be at the nodes, or it can be at any distant sites. So all need to be evaluated. And if you have treated with radiotherapy, then please look at the thyroid profile 6 months post radiotherapy. Start doing his thyroid profile every 6 months to 1 year. And if required, please give Eltroxin. Otherwise, patient will develop myxedema. I've already talked about this. Adjuvant therapy, all of you know, stage 3 and 4 adjuvant therapy has to be given. Multimodality treatment has to be done. And multimodality, if it was CCRT, already 2 modalities are being used, if you have chosen organ preservation protocol. Stage 3 and 4, basically, multimodality treatment. If you have chosen surgery for definitive treatment, then adjuvant therapy in the form of either RT, or if it merits chemo-RT, then you have to give chemo-RT. Chemo-RT indications, all of you know, 2 positive margins and extranodal extension. Okay, few case scenarios. We have some time. All of you will have to answer these. 63-year-old male, dysphagia and swelling right side neck, FOL lesion you can see in the right side hypopharynx. In the CT scan, you can see a node in level 2. DL biopsy, poorly differentiated squamous cell carcinoma. Anybody can tell the T and N stage, and if M0 and performance good, what treatment should be offered? T3, N, at least N2, and if there is, to me it looks as if there is some extranodal extension also. So N3. So if it is T3, N3, what treatment you like to offer? CCRT. CCRT followed by salvage surgery if required. Okay, in this picture, what surgery can you make out? Total laryngectomy, okay. Total laryngectomy, and this is the remnant pharyngeal mucosa. Now, we have placed a scale here. What is the reason for placing the scale here? Yeah. To measure 3 centimeters of unstretched mucosa is required. Very good. So, for that we need to know how much of the remnant mucosa is there. Okay, another scenario. 68-year-old male, chronic smoker, known case of CA hypopharynx old, has been treated with chemoradiotherapy, and he has a residual disease in the post-recovered area. What will you like to do? What treatment? Performance is good. Why? It is M0, na? M0. Okay. No, why? Why can't you do surgery? Salvage surgery not possible? Cricoid is only one. No. Anybody else? Salvage and if N is positive, then we do neck dissection, otherwise you will not do, and reconstruction with reconstruction. You will require, because in the post-recovered area, as you go down, the remnant mucosa will be very less. It will be very small. So you need to do a total laryngopharyngo esophagectomy also. Maybe gastric pull-up, or you can do a jejunal flap reconstruction. This is one of the cases we have done, total laryngopharyngo esophagectomy. You can see the remnant post-recovered lesion, and then gastric pull-up was done, and patient is doing fine. Another scenario, 40-year-old male underwent total laryngectomy with bilateral neck dissection for advanced CA larynx. Final HPR is this, you can read it. What is missing in the final HPR to decide your adjuvant treatment? Size of tumor is given, margins are given, number of nodes positive is given, LVI PNI is given, extracapsular extension. So extracapsular extension is required. Please ask your pathologist to report. If they don't, then you can't decide on adjuvant. Next situation, 55-year-old male received definitive CCRT for stage 3 hypopharyngeal cancer. Pre-treatment voice and laryngeal function was good. During second follow-up, he developed recurrent aspirations manifesting as chronic cough. So, and when we evaluated the patient, there was no evidence of any locoregional disease. So, what is the likely diagnosis for his aspirations? Radiation has effects on vocal cords. So it can gradually cause fibrosis, fixation of vocal cords, which may lead to aspiration. One is that. Second, if the tumor was abutting the cartilage and there is some chondronecrosis, then again aspiration can occur through a hole in the larynx in the post-recovered region. 61-year-old male diagnosed as a case of CA larynx, subsite right TVC T1 lesion, underwent transoral laser surgery, type 2 cordectomy. Final HPR is this. Closest cut margin is 2 millimeter. What should we do? Any adjuvant treatment required? Anybody? So in glottis, even 1 millimeter margin is okay. In your vocal cords, you don't need 1 centimeter margin. Even 1 millimeter margin, clear margin is fine. You may just observe the patient. Situation 4, 55-year-old lady presented with hoarseness of voice, 4 months duration. Scopy revealed growth, left false vocal cord. Laryngeal surface of epiglottis, left vocal cord is immobile. CT is suggestive of inner perichondrial thyroid cartilage involvement, along with supraglottic epicenter of disease without any neck nodes. So what is the TNM? T3. So inner perichondrium involvement will still make it T3. Modality of treatment, organ preservation. Fifth situation, 60-year-old male, case of advanced CA hypopharynx. Advanced means T3, T4 at least. Laryngeal crepitus is preserved, however, CT revealed prevertebral space involvement. This is the last case, 51-year-old lady diagnosed as a case of advanced CA larynx, underwent definitive CCRT, presented during follow-up at 6 months. In what scenario will you do rigid and flexible scopy in follow-up? I have explained all this. I think you know when to do DL scopy and when to do FOL. And if is PET CT required, when it is required? Is PET CT, suppose you do a scopy and you find a small erythematous or small ulceroproliferative area, disease is there. Would you like to do a PET scan? Yes or no? Anybody else? So please remember, all recurrent or residual diseases, we will like to do a PET scan, because sometimes what happens is, in post-therapy settings, there are granulations, there may be just some erythematous area which is not positive. And if you do a biopsy without doing a functional imaging, then later you cannot go. Suppose that biopsy turns out to be negative, but still you are not sure. But if you had a PET correlation prior to taking the biopsy, then it would give you more information. So PET scan in all recurrent and residual cases, we will always do a PET scan before doing a biopsy. So these are some important questions which are asked in the exams. I think all of you know the answers. Anybody wants to ask? Need for cricopharyngeal myotomy in post-laryngectomy to prevent neopharyngeal stenosis, to prevent dysphagia, as well as help in voice rehabilitation so that the air can go up. Which one? Yeah, you tell. I'm sure you know. 66 to 70 gray. Definitive therapy. And in adjuvant settings, we use up to 60 gray. Okay, that's all from my side. Any questions from you? If you don't know any answer, you can ask me. Minimize radiation-induced chondronecrosis, IMRT. IMRT, 3D conformal RT, whatever. I mean, whatever best you have, you use that. Okay, thank you.
Thank you, ma'am.